Welcome to Clerkship Paradigms, your travel guide to the third-year clinical clerkships. In this series, we discuss the approach to patients and the tools you need to be successful in each specialty. Emergency medicine is a focused specialty that relies on a unique approach to patient complaints based primarily on the acuity of the presentation and the most likely life-threatening conditions that could be possible. The history and physical exam are more focused than you might perform in other rotations, and the goal of patient management is on initial stabilization. The greatest difficulties third-year students have during this clerkship are, number one, creating a discrete differential based on categorizing by acuity. Number two, taking initial temporizing measures. And number three, determining the level of acuity and thus the disposition of the patient. So how does one think like an emergency medicine physician? Think back to your preclinical years with your clinical skills classes and case-based learning activities. You've been working hard on your broad differentials and your broad scope of care. And you go see your first patient on day 1 of EM, what's going to happen? You'll get your detailed HPI, your thorough history and physical exam, and you'll have a thoughtful differential, and you'll eagerly go back to your attending to present the patient. But you'll be cut off mid-presentation because you've approached this without categorizing the patient's complaint by acuity. That entire approach, differential, workup, plan, they're all based on the primary care medicine goal of what does this patient have? In addition to figuring out what the patient has, in EM, we have the added task of categorizing the differential by acuity. So what does the categorical approach entail? In EM, our primary tool is the deadly disease drop-down. For a given presentation or chief complaint in the ED, there are a handful of emergent, life-threatening conditions that are our job to rule out. We aren't starting from a couple of symptoms and growing a field of possible diagnoses, but rather, we are starting from that discrete list of life-threatening diseases from an individual chief complaint, our history and physical in the ED, along with a discrete set of readily available and time-sensitive diagnostic tests, are thus focused on evaluating for those life-threatening conditions. Once we have evaluated for the emergent conditions on our deadly disease drop-down, we can safely begin working up for urgent or non-urgent conditions while providing initial management and planning for disposition. So what is the emergency physician's role in caring for the patient? Management of a patient in the ED is similar to that of an inpatient ward or an outpatient setting, but with a more narrow selection of diagnostic and treatment options due to the limitation of time. Once you have characterized the condition, ask yourself, what immediate measures can help this patient's condition? We like to call these temporizing measures. For example, it is not possible to treat the patient's MI entirely in the ED, but rather, you will provide stabilizing care in preparation for that patient's transfer to the cath lab or the CCU. Recall the Mona Bash mnemonic from your preclinical content. We can deliver oxygen for low SATs, morphine for pain control, and other measures the ED has on hand that can be given rapidly. After the emergency workup, the next thing the ED physician wants to determine is where the patient needs to go now. That is, their disposition. After all, the waiting room is full of more patients to be seen. Determining whether the patient should go home, stay in the observation unit, or be admitted to the hospital is a difficult skill that ED providers develop with years of experience. However, you will be expected to make a recommendation to your team about where this patient should go next. Some situations are easy. A patient who is suffering an MI clearly needs to be evaluated further and treated given the severity of the condition, so he will be admitted. However, not all patients have such a straightforward disposition. Ask yourself, have I successfully ruled out the possible life-threatening conditions, and can I decrease the level of acuity of this patient's care? Let's introduce our patient, John Dispo. Hi. To better understand the EM approach, John is a 20-year-old male presenting with a headache. As with a general inpatient service, You will eventually obtain a full history and physical, considering non-emergent causes. But in the ED, your mind should immediately jump to the deadly disease drop-down for headache. These are subarachnoid hemorrhage, meningitis, hypertensive emergency, temporal arteritis, hemorrhagic stroke, epidural hematoma, and acute angle glaucoma. These are acute threats to the patient's health that need to be ruled out immediately. Temporizing measures for this patient would include pain management, blood pressure control, elevating the head of the bed, and decreasing light stimulation. John's disposition, if an emergent cause is identified, will likely be admission. But if not, depending on the severity and duration of the symptoms, it could be either observation or discharge. The unique patient categorization approach in this specialty makes the ED rotation an excellent opportunity to start developing differentials for specific complaints, a skill you will develop for any field you pursue as a career. To summarize, emergency medicine is a fast-paced, high-turnover service that will challenge you to learn to think on your feet as a third-year medical student. Remember to work on developing a deadly disease drop-down for the most common chief complaints, which utilizes patient categorization via acuity. Practice assigning dispositions to all the patients you see on this rotation in order to develop your skill in determining the level of care that patients ultimately require. And finally, always consider a thorough set of temporizing measures to treat the patient's immediate problems while he or she is under your care. Thanks for watching Clerkship Paradigms, your travel guide to the third-year clerkships. Please fill out the post-video survey and tell us your thoughts. Good luck on the wards.